Shalini Jaggi, a discussion on hyperglycemia in pregnancy. Now, hyperglycemia in pregnancy, or not just about gestational diabetes, but specifically in gestational diabetes, is really a very important topic that we all face in our clinics. Many ladies who do not have diabetes found that their blood glucose level is high during pregnancy. And of course, this is very much related to obesity. So all the discussions that we had earlier about the weight and the lifestyle is very important for a woman who is married, want to have children, because her lifestyle before getting pregnant is very much going to affect the outcome of the potentials of having hyperglycemia in pregnancy. Now, when I was working in UK, pregnancy was very much planned. The vast majority of ladies would have it planned. Now working in Dubai, planning doesn't exist. Many ladies there, they are happy to get pregnant whenever it happens. So it doesn't need too much planning. And obviously this is a concern when it comes to diabetes, because many treatments need to be adjusted and lots of arrangements need to be planned in advance. So we have some data from the IDF Atlas. This is data from 7 years ago or 8 years ago about the prevalence of gestational diabetes in our region. Now, I'm not really sure on how accurate the data is, but nevertheless, there's important data that's out there that is saying that a good proportion of people, age-adjusted prevalence is 17.7%. So that's almost 20%. Last year we published, I think it was last year, perhaps the year before, we published the International Diabetes Federation MENA region, Middle East and North Africa region guidelines for hyperglycemia in pregnancy. It included a large group of colleagues from many parts of the region, including Professor Lubna Touni from Asyut, from Egypt. So whom should you think of gestational diabetes? Who should you start saying, I need to screen? Of course, we need to screen everyone in our region because we are high risk. But perhaps you would come across someone who is more at risk by virtue of their own personal or family history, or their medical history, or their previous pregnancy, or because of the current pregnancy. Many of the important factors we need to think of: someone with advanced age for maternity, above the age of 35, and that's the common nowadays. In the guidelines it says advanced age. Nowadays, that is the average age. I see many ladies in their 40s who are pregnant. I run the diabetes antenatal clinic, which I do weekly along with my colleagues. And it's a joint clinic where I sit and next door is the obstetrician. So the age of pregnant ladies nowadays is very much older, one, because of career development. Many ladies get pregnant later in life, and because obviously they are looking after their career. So the screening means we need to have criteria for diagnosis, and we have different criteria for diagnosis. Here is some of the internationally applied ones. There are more on this, and I'm sure this will be covered in our discussion later today. So we have the International Association of Diabetes and Pregnancy Study Group, which established the recommendation in 2010, and they look for fasting of 92 to 125. For the ACOG, their fasting is slightly higher, 95 to 125. And then you go to NICE recommendations, where their fasting is even higher, starting with 100, and the all cutoff is 125. For the 2 hours, the IDAT is 153 to 199. The ACOG is 155 to 199. And the NICE recommendation goes down to 140. So, as you can see, 3 important bodies are not agreeing on the simple criteria for diagnosis of hyperglycemia in pregnancy, gestational diabetes. And that's obviously is a cause of concern. I here put for you one of the important studies, important from the point of the methodology. This is a study that was done in northern parts of India, and they looked into 3 different centers. And the data, the results are completely different. The data from Delhi are very different from the data from Muzaffarpur, and their data from, I cannot see the slide, the screen very clearly, from Billari. Why is it so different? Because the methodology applied in each center is different. So if I am a patient with pregnant and I go to one city and then, let's say, my job change or my social circumstances change and go to a different city, where the doctor will be applying or the center will be applying a different criteria. One of them would say to me, gestational diabetes, the other one would say normal, or vice versa. So when you look also into data from Pakistan, the study done by Dr. Musarrat Riyaz and included Shabin Masood, a very good colleague that we know from Pakistan, they looked into the DIPSI data, and the DIPSI is the Diabetes in India Pregnancy Study Group, correct? I hope I got it right. Now, they are concerned that the vast majority of the 3 guidelines I've told you about are talking about a person to go for a glucose tolerance test on a fasting basis and wait for 2 hours and then have the 2 hours blood test. And from a pragmatic point of view, they feel that many do not do this. Many, because of logistics, the patient come to your clinic in the evening. Maybe the patient will not come again for a few weeks or few months, will not have the time off. So they wanted to have a pragmatic approach. And the DIPSI recommends doing an OGDT 2 hours after taking the test, regardless of the time. So you're sitting in clinic in your evening or your afternoon, and you say to the lady, drink the 75 grams, come 2 hours later, and let's have your blood glucose level. And if it's above 140, you have gestational diabetes. Very pragmatic, very simple, and straightforward. But does it fulfill the criteria for everyone? Now, this is the data of the result. So they've shown that only 10.2% had gestational diabetes, and it was very different between one city to another city, which obviously needs us to understand what is the difference between Karachi and Hyderabad. Why would the value be almost double between one city and another? We need to understand, obviously, the dynamics and the logistics in each city. But what surprised me in the study is this category, which I do not know what to do with. So normal is normal, GDM is GDM, and overt diabetes is overt diabetes. But what is gestational glucose intolerance? How do I address this problem for a person who comes not GDM, but not normal and not diabetes? What do I say to this lady? Be careful, do what? So that's something that we need obviously to think of. Our colleagues in Almenia, they did a study a few years back and did the exact protocol of DIPSI, and they came up with, they applied 2 different protocols, the DIPSI protocol and the IDPES protocol, and there was a difference between 7.4 to 8.8. You might say this is a small difference, but this is about 15 to 20% higher between one protocol and another one. This is an important trial which was done by Khalid al-Rubayyan and colleagues from Riyadh, from Saudi Arabia, and they looked into a huge data set. They decided to go through the fasting plasma glucose of over 92 according to the fasting criteria. So they did not go with a 2 hours test, just the fasting here. This screened huge number of patients in their going to their clinics, And they came up with 32.4% had GDM according to the fasting level. So what they ignored here was the 2-hour test, and what they focused on is the fasting test. And the figure came with a very high level of gestational diabetes. Another study which was done in Jordan, and they looked here into women who were working in the university hospital. And they screened 644 persons with singleton pregnancies, screened with the classic 75-gram glucose tolerance test, with a 2-hour test, and they applied the WHO criteria, yet another 5th category or body, giving us different levels of diagnosis. Where here then the fasting is above 92, 1 hour above 180, and 2 hours above 153. And they came up with that of 87 pregnant women were found to have gestational diabetes with an overall prevalence of 13.5%. Of these 13.5%, 64% of them were diagnosed with a fasting test, and 19.5 with 2 abnormal tests, and 16.1 with 1 of the tests. So let me clarify. This does not mean 64% had gestational diabetes. No. What I mean is, out of the 13.5%, 2/3 of them were diagnosed with a fasting test, and another 20% or so were diagnosed with 2 tests, and 16% with 3 different tests. The study done from Morocco, and I'm just giving you different flavors of different studies from our region, because ethnicity and genetics are important here. And in their study, they looked into fasting of over 92, or 0.9 if you talk about gram per liter, and 101.25 or 125 milligrams, and they came up with 24.2%. Now, I would like to share with you some data of studies that we've done in Dubai. We looked into a large cohort of patients from delivered in 2016. So we looked into all the deliveries of the 2 obstetric hospitals in Dubai, and this was 7,643 pregnancies, deliveries, split between Emiratis, and we selected the Indian subcontinent expats. So we considered that other Arabs would be probably similar to the Emiratis, so kind of trying to find 2 different ethnicities. And we looked into the different criteria that would be applied. And here is the data presented between UAE nationals versus expatriate women, which was exclusive to the Indian subcontinent. Very much matching in everything. And here is the prevalence in the Emirati ladies. Total prevalence was 23%. Diagnosed by the 2-hour test was only 7.9, nearly 8%. And diagnosed by the fasting test was 15.1. And obviously, when you add them up together, they come to the 23. When we look into the people from the Indian subcontinent, a very different picture. It is kind of 50-50. 10% are diagnosed with the 2 hours, and 10% is diagnosed by the fasting. So the total was 20.2%. So clearly, when you look into the different criteria, so here is fasting blood glucose, blue is UAE, and orange is the expatriates. 2 hours and the total. Clearly, there is big differences between one community and the other, even though they are living in the same city, which means that the tests need to take into consideration what is my genetic background as well. And in this particular slide, we looked into the different options of diagnosis. The IASP would diagnose the most, 23%. The American College of Obstetrics and Gynecology would diagnose the least, 18.5%. And eventually, the NICE guidelines would diagnose about 20%. In essence, it's not terribly different. Let you say 20% plus or minus 2. But you can see the very huge difference in the Dubai nationals with the type of methodology, whether it's the fasting or the 2 hours. Equally, when you go to the expatriates, mostly from the Indian subcontinent, the average still again is about 20 to 21%. Not terribly different, but different methods used. So if you ignore the fasting glucose here, it will be according to what tests you're doing, according to what methodology you're doing, maybe diagnosing far much less or maybe diagnosing a lot more. So we wanted to look into another important point. Gestational diabetes is important for obviously the current pregnancy, but gestational diabetes is also a risk factor for developing type 2 diabetes. And we looked here into the utility of glucose tolerance tests after gestational diabetes in predicting the conversion into type 2 diabetes over the years. And here in gray is the percentage of women who had gestational diabetes and developed type 2 diabetes into the years, and what was the profile. So obviously the BMI is very important, and parity, number of children the woman had before, is very important factor. 6.3 here was a very important factor. And this was also very much similar to what we saw in our paper, looking into the different methodology. If you want to ask yourself, what would be the risk for this particular woman to develop future gestational diabetes or future type 2 diabetes, one of the important factors is number of previous pregnancies, the parity, which was really quite high regardless of the methodology. So, and that was also seen in the Pakistan data when they applied the DIPSI. So one of the very high important factors was the number of multi-gravida had much higher rates compared to the primary gravida. So ladies and gentlemen, in summary, I put one of the important points of screening and diagnosing. So the classic, the gold standard is the glucose tolerance test of 2 hours, measuring both the fasting and the 2 hours. I understand and I appreciate that for some, because of logistics, because of the resources, it might not be feasible. And consequently then, to go from the DIPSI would be an attractive option for those who are not so keen on fasting the following day, the following week, to come up with a diagnosis. HbA1c is not a tool to diagnose gestational diabetes because the bone marrow is hyperactive during pregnancy. So the bone marrow will be naturally much lower, so we should not do an HbA1c on a pregnant woman to diagnose the condition. You might use it to monitor progress if you wish, but for diagnosis, it is really not recommended at all. The prevalence of gestational diabetes in our region is pretty high, which is obviously related to a number of factors, including our lifestyle. Our genetics has not changed, but what has changed over the years is our lifestyle. Screening in our region, it needs to be done at booking time, and then if negative, to be repeated again at week 28 because of the high prevalence of gestational diabetes in our region. And of course, we need to develop preventative programs so that women with gestational diabetes apply for, take over, and prevent future type 2 diabetes or indeed future hyperglycemia in pregnancy. Thank you, and I look forward to your questions.